findings. This patient will say, Doctor, aap Bhagwan ho. Within 6 hours, this patient burning will disappear. Their sensation will come back. They will say, first time I am sleeping so comfortably. It's such a fantastic surgery for diabetic neuropathy, and your physician do not offer any treatment to them. Okay. And you offer them such a treatment which can relieve their all symptoms. It is very disturbing for a patient to have a diabetic neuropathy. They have gone up to going for suicide. I have patients who said, sir, if you would not have operated, I would have suicided. So this is the problem of diabetic neuropathy, can be solved by simple surgery.
Thank you. Sir, how many holes you would do?
I told with the gap of 1.5 to 2 inches in a spiral fashion.
Not posteriorly.
Anteromedial, posteromedial, anterolateral, posteromedial, anterolateral, like this zigzag.
And whether this can be helpful in traumatic also?
Vascularity increasing surgery. If there is a vascularity compromise, this will help.
How this increase the vascularity?
With Ellizarov's principles. Is as good as osteotomy effect. It increases the vascularity because of insult to the bone.
What drill you use? What
comes through the bone?
Pardon me?
Yeah.
Blood supply comes through the bone to the tissues or perivascular?
See, it is a reaction of the body to increase the vascularity, and it do not spare soft tissues also. It gives blood supply to the soft tissues and bone both.
Thank you.
What drill you use for
3.2. 3.2.
2.2.
3.2.
3.2. Okay.
Yeah. See, Professor Sheshsaw advocated me to drill the complete 2 cortices. I went initially in few cases of multiple drilling with both cortices, and I had 2 complications of a stress fracture. And then I realized that why to increase the risk by doing multiple, both cortices. And I started doing only 1 cortices, and I got same result. So I decided not to do 2 cortices, but do single cortices. So there is no protection, no brace is required, patient is comfortable, and no risk of fracture. Any question? Yeah. Vascular claudication can be helped with this technique. Are you treating patient of diabetic foot? Are you treating? No, that's why this is a question. The person who is treating diabetic foot will not ask this question. Why? Because diabetic foot is a neuropathic foot. Whatever implant you will put, they will break it and will bring in your hand. So these patients do not have sensation. They will walk and they break. That's why all the cases have failed arthrodesis in a neuropathic foot. Only illizarov can succeed, which has got a better strong hold on the foot and patient cannot break. Remember, don't try to do internal fixation in a diabetic foot arthrodesis. You will fail miserably. Infection, breakage of the implant, and non-union. These are the 100% complication. Fuse with Elizarov and there will be no complication.
So you can go for drilling in the lower side also?
Yeah. See, somebody was asking me about this is the drilling which is done. 1, 2, 3, 4, 5, 6, 7, 8. Multiple drilling in a zigzag fashion. Posteromedial, anterolateral, posteromedial, anterolateral. If you have got an ulcer on the foot on a great toe, then you go up to the great toe. Where is the ulcer? By drilling. You can drill into the foot also. Remember one thing. Wherever there is a gangrene, you cannot change that gangrene. So don't promise that that gangrene will be also changed. Tell the patient, whatever is dead, I cannot change. But there is a possibility that we can save your leg. No. No, if there is a unstable ankle, there is a Charcot foot ankle, then only arthrodesis is done. If there is no problem in the foot and ankle, why to arthrodesis? No need.
Stand till the foot. Drilling.
Depends on the ulcer. Where is the ulcer?
The
Follow-
drilling is through and through to the cortex,
Single-
double cortex or only one cortex?
Single cortex, single cortex.
Different directions, single cortex.
Single cortex. And very important, how much time, nobody has asked me this question, how much time this effect lasts. See, once we are done surgery, patient recovered, his ulcer is gone, his vascularity is increased, how much time it will last? I have got 3-year follow-up now where the angioplasty is still working. You should do color Doppler, pre-surgery and post-surgery. Next day color Doppler, you will see the posterior tibial, anterior tibial absent will be present in a color Doppler. Your color Doppler radiologist will tell you, sir, the vascularity is increased. The monophasic has become biphasic. The flow has increased. The collateral circulation has increased. And that will open up your eyes. Yes, this surgery works. Next day, within 24 hours. Yeah. See, if you have got a one toe amputation, you do, but the wound healing will be fastened by this technique, will increase. So the problem of wound healing and amputation will not be there. Thank you.
I am saying.
Spinal anesthesia, short spinal, which we can say caudal with a less risk, which will last for half an hour.
वो तो हो गया कल ना?
हाँ हो गया एसटीओ बोल दीजिए सर
हाँ.
रजत
Okay, thank you very much.
Sorry, I am taking this time because I want to go for my flight, which is early. I am talking about fracture around knee joint. This is a one-step management of a fracture around knee, floating knee with illizarov. You all aware about the floating knee is a lower third femur with an intra-articular fracture, which shows a complex fracture, a complete destruction, and this is usually a bike against a truck, which destroys the complete knee joint. One-step solution to all fractures. This is the advantages of illizarov. It is a close fixation. We have to span the knee joint, early weight bearing, early mobilization of the extremity. After full union, quadricep plasty is required to get the knee movements, and bone grafting is most of the time required. You all aware about Gustello's classification, and Gustello say when there is a 3-week bad infection, you should use external fixator, and we decided to use this illizarov fixator. There are 2 types, with a bone loss, without bone loss. If there is a bone loss, you do acute shortening, excision of the bone ends, bone grafting, corticotomy, and use fibula if there is a big gap. Without bone loss, you align, closely fix, and if segmental fracture, you add the bone grafts at the site which is supposed to go into non-union. This is the X-ray which has to be investigated by CT scan and coronal fracture configuration. You will come to know wherever bone loss, how is the articular surface, and what is the sizing of the ring. And as I was telling in a workshop, the size for the femur is 200 and up. It cannot be below 200. This is the usual injury where the femur buttonholes to the quadriceps when there is a head-on collision. And if you do close, then you will get muscle entrapment into the bone ends and you will land them into non-union. So open this fracture, remove the buttonholing, and get the reduction of this fracture and remove the buttonholing. And you can do a intra-articular alignment by fixing with a minimal screws like this. And alignment of the intra-articular surface is achieved. And this is the fixator which is applied. You can see here, there is a for femur. And this is minimal internal fixation for alignment. And you can see you require bridging of the tibia most of the time. If you leave tibia free, most of the time this fulcrum acts on this fracture and goes into non-union. So you have to neutralize the forces of a knee movement by bridging the knee. Acute shortening is done most of the time to avoid the delay in a union. So remove the dead bone, necrotic bone, shorten the leg, and corticotomy higher up, simultaneously lengthening is done. So technique is open reduction most of the time to remove the entrapment. Acute docking is achieved in most of the cases, and temporary fixation done like this by cross K-wire fixation. Most of the time you land up into sagging, and this can be solved by shifting the apparatus down one level by connecting plate, and the reduction can be achieved. As I showed in the tibia, if there is a femur, you can use this 4-hole plate technique to get the reduction. And this is a clinical case where there is a severe injury with a multiple fractures in the extremity around the knee, and this should be fixed on a fracture table with a traction and a surgical fixation, illizarov raising as per the Russians method by multiple pin fixation first, and then erecting the frame from top to down and correcting, getting the fixation done. This is a complete frame. These are a few cases where there is a complete loss of the bone, comminution, intra-articular fractures around the knee, and there is a tibia fracture also. And you can see acute shortening, fibula is added here, and there is a corticotomy for getting the length back. The tibia is also reduced with illizarov, and this is a corticotomy, and you can see the good consolidation happening here, and there is a corticotomy regenerate. This is a good regenerate here, and fracture is uniting. And this is a weaning. Very important, illizarov surgeon is a real illizarov surgeon, successful surgeon, if he knows when to remove illizarov. If illizarov is removed a day before, it is a failure, but 1 month later is a success. So remember, delay and wean the fixator as far as possible, and this is a weaning of the fixator, removing one ring by one ring and rods, and allowing patient to move, mobilize ankle, mobilize knee, and here the protection after removal is must. This is the video which shows the patient is walking comfortably. Few people will ask me, why not fix internally? Why not have a knee movement? Definitely. But see the complex fracture, open fracture, grade 3 fracture, infected fracture, we will not dare to fix it. There is a bone loss. So all this complex fracture require external fixation, and there is a knee which is going to get fired. But quadricephaly is a solution to that. There is another patient with a severe fracture around knee, and you can see this is minimally internally fixed and externally by illizarov fixator, acute shortening and lengthening higher up. You saw oblique osteotomy. If you don't do multiple drill, you will ask me, sir, there will be shattering of the corticotomy, and it is going to happen better for you, because there are more species, the better is the regenerate. So, but that doesn't mean your trauma should be more. You should be least traumatic to the body, but if it shatters, doesn't matter. And you can see the regenerate is happening good, and complete union and both fractures. There is another patient with a bone loss, and you can see there is a lower tibia fracture also. And this is again acute shortening, 4 to 5 inches of shortening, and fixation for intra-articular fracture alignment. Tibia is also fixed, and there is a corticotomy higher up. And you can see the lengthening is happening higher up. This is a complete union picture, and this is clinical result. This is the initial movement, and they later on quadricephaly gives 90 degrees. And this is the video which shows this patient is walking painlessly, comfortably with a shortening of 1 inch to avoid the problem of knee stiffness, lurch. So we have kept 1 inch short. So post-frame reveals, you can get 90 degrees results like this, but sometimes you require quadricephaly. So fracture fixation by illizarov requires proper indication, selection of patients, and preoperative planning and analyzation of fracture. Reduction can be achieved by open reduction or using variety of devices. Bone grafting is indicated in segmental fractures, bone loss with acute docking. Before removal of fixator, proper dynamization of the fixator is must, and Dynamization can be done with a C-arm to know whether you have got a complete union. Thank you. Any questions on this?
Thank you very much.
Yeah.
Any question, please?
During the application of the illizarov in the floating knee, what will be the position of your thigh and leg?
I showed the position on a fracture table.
Straight away?
Straight away, because
Then you can invite.
knee stiffness. Knee
Yes.
stiffness, I know. But this is a complex fracture. And the method of giving a traction to the both fractures and maintaining the alignment was difficult without fracture table. But if given a choice today, I will do a wire technique to the femur, give traction with a 90 degrees position of the leg. So fix femur first and then tibia with hinges.
Or you can put traction over the tibia, put the leg 90, so that you cannot invite any kind of tension in the femur.
Yeah, but Dr.
Then-
Bari, there are certain patients who had a shattered tibial condyle.
Yes, I understand. I'm talking about the only your case, floating knee, and we are doing like that.
Yeah, but if there is a shattered tibia condyle, shattered lower end of femur, very difficult to hold the tibia and femur and give traction. With experience, we can do a lot of shortening. But for beginners, I will say 4 to 5 centimeter is a safe shortening. More than that, you should be experienced illizarov surgeon. You should have a Doppler inside the operation theater, and after docking, you should check whether the pulsation are present or not. And pre-operative pulsation should be checked. This is the biggest important mistake orthopedic surgeon do, that he is not aware whether pre-op pulse was there or not. And then you are in a stuck position whether the pulse is gone now or was absent before. So always Doppler before surgery, Doppler intra-surgery and post-surgery also. Yeah. In Maharashtra, Mumbai, the Dipel India company, and I have got a phone number of that person who can provide you. You can ask me in my hospital landline number. You will get the number. They provide in 6,000 excellent orthopedic Doppler. Even digital artery can be heard. If there is an amputation of the finger, medico-legally you can be challenged why you amputated. You can prove by this Doppler there was a vascularity we have checked by Doppler and it was absent, that's why we amputated. So it is a medico-legally also very important to have Doppler.
Another one question. Do you do anything regarding the ACL, PCL, and bilateral collateral ligaments injury with this floating knee?
Most of the time these fractures around the knee cannot be tested for ACL or PCL. This can be tested post-operatively once you fix everything, then they can be tested. But usually they land up into stiff knee, so ACL and PCL and collateral is not a question because the treatment span is 9 months to 1 year. So patient is usually land up into stiff knee. So that's not the problem.
Thank you very much, Dr. Sohar.
Thank you, sir.
May I invite Dr. R.A. Agarwal to talk on high tibial osteotomy. Fine, acha. Good, authoritatively to talk. वो गोवा का एक एडवर्टाइजमेंट देखता हूँ ये इस पर डाल दो ना अच्छे डाल सकता है क्या हाँ मेरे पास पेन ड्राइव
वो प्रेजेंटेशन आपके इसमें डाल देते हैं पावर पॉइंट प्रेजेंटेशन डाल देते हैं आपके पास ही रहेगा
most common degenerative disease of the mankind. Medial compartment is affected more commonly even in the younger patients. Dome osteotomy first described by Brackett for ununited fracture of the neck femur. Jackson and Watt found it satisfactory for upper tibial region. Now we come to the history of the proximal osteotomy. Jackson and Watt in 1961 osteotomy, he has recommended the osteotomy distal to the tibial tuberosity, diaphysis, closed wedge or dome distal to the cora. This was the first. The conventional closed wedge osteotomy proximal to the tibial tuberosity. And then McCoy had done dome osteotomy proximal to the tuberosity and distal to the cora. Now, first of all, when we do the osteoarthritis knee, we have to know the biomechanics is very important, and the hip, the biomechanics is very important. In normal knee, loads that are 2 to 4 times of the body weight is imposed on the knee joint. 60% of this load passes through the medial compartment. In genovirus, more load is imposed on medial compartment. Altered biomechanics accelerate degenerative process and increase pain. Dome osteotomy redistributes the load to the uninvolved compartment and provides favorable conditions for the regeneration. What is your preoperative planning? Physical examination, range of motion at the knee. नहीं तो मरीज कहेगा साहब पहले तो ज़्यादा मुड़ता था अब कम मुड़ रहा है. Knee instabilities, Q angle at the knee, any foot and ankle deformity, legless discrepancy, preoperative photographs and video. So that you can show this was your preoperative movie and this is a postoperative. So radiographs, a full length radiograph from hip to neck ankle in standing position. This draw at the mechanical axis line from here to here, cora and magnitude of the correction, how much you will correct that. For how much you will correct that, this is the fusiva point is there, so that in the mechanical axis line will pass through this line. It means it divide 0 to 100, so it passes somewhere in the 30 to 40%. These are the various ways you do the mechanical axis line and how to draw the theta angle you have to provide. You will know about the illizarov mechanical axis correction. Now, it is our young man, this is about 58 years. We have taken a full radiographs. So he was having 10 degree varus and 9 degree varus or the left knee joint. So usually what we take the load bearing stent space. Stent space is a 10 degree and the left side it is a 9 degree. It's very necessary that stent space X-ray will come that. So now what we have done the dome osteotomy here. We have done the fibula osteotomy here and dome osteotomy here, and that we have here we applied. So very simple procedure, one ring here. We have given 3 wires, 1 screw, and here 2 screws, and here 2 wires. So we have achieved the 7 degree of the valvus. Normal is a 6 degree of the valvus. So 5 to 6, so 7 to 8 degrees is the normal. To 2 degree of the overcorrection we can have that. So we have achieved the 7 degree of the valgus. Now it's a left knee. In the same way we have done here the open wedge osteotomy here. We have done after 3 months when the patient was walking. So you can see in the both the cases we have applied 7 degree of the valgus. That is normal needed. It's our X-ray monitoring. This is the final radiographs. We are following these cases for 10 to 15 years. So we are very much worried because we have done the fibula osteotomy. Some people are not doing the fibula osteotomy. There are more chances of the recurrence because fibula is the pillar that is producing the deformity. So we are following these cases for a very long time, and after 2 years we have found the 7 degree of the valgus which we have done has been achieved there. Now it's a 5 degree follow-up, 5 years follow-up. Same 5 degree if the patient doesn't increase the weight, he is doing the knee exercises, he is doing the bicycle exercise, we will show you the angle which you have achieved. It will continue for 15 years. We will show you. So it's after 2 years, it's a stent page photographs. This is stent page photographs after 5 years. We are studying after 5 years. Same angle is maintained there. Same angle, 5 years, long X-ray we have taken under 7 degree valgus. It was initially, which you have to use, it is maintained there. Now it is movie. It was a pre-operative movie, walking with the varus thrust. Now you can see that it's a perfect. When you do surgery, it should be perfect. It is a 5 years follow-up. It's a perfect correction of the deformity, full range of movement, no pain at all. Now, Dr. Agarwal, Lesson Agarwal, I want to have what you will do in this case. 40 degree varus, patient was not able to walk, great difficulty, what you will do. You will like to see the X-ray also? Yeah, this is the X-ray.
I think first we should decide the label and
No, it's a came cast to you. Will everybody do the total TKR? Yes, Dr. Bhatia, I think everybody do the TKR. Otherwise, what you will do, Dr. Srinivasan? Yeah.
STO as well as
Yeah. What is the opinion of
Fortunately
the
tumor
house?
also.
What you?
Think about the type of the Ahalbart type. There are 5 types of osteoarthritis of the knee. This is type 4 and type 5. And he's suggesting that you don't, if you do a STO in type 4 or type 5, you can get result, but ultimately after 5 or 10 years, the patient will come back again in the same situation.
Same
His
per
advice
TL.
is you go for STO type 1, type 2 and type 3. For me, this is type 4.
Yeah, this is very interesting discussion, and I have got a lot of patients of STO which are done in type 4 and type 5 osteoarthritis, where the patient is not preferring total knee replacement. I offer them high tibial osteotomy. We have conducted in Bombay high tibial osteotomy symposium where Japanese surgeon has come. In Japan, they don't do joint replacement and they do only high tibial osteotomy because their sitting habit, eating habit requires Vajrasan, which is not possible with a TKR. And sir has shown in Japan 35 years follow-up of high tibial osteotomy in grade 4, grade 5 osteoarthritis. So we were amazed to see that result. Where the TKR was the only solution in our mind, he had offered high tibial osteotomy and the patient had a result up to that long. They have shown regeneration of the cartilage on the medial, burned out cartilage, subarticular bone is opened, still the cartilage reappear. I have one slide which clear-cutly shows that I have done high tibial osteotomy, patient developed lateral compartment osteoarthritis, so I went for total knee replacement. I opened the knee. After 15 years of STO, I saw the medial compartment when I opened the knee, the cartilage was completely regenerated. So we are a victim of a companies who are selling total knee replacement.
Yeah.
I saw patients
Okay.
in Mumbai, 30 year, 35 year, operated for total knee, first time complaint knee pain. This is ridiculously happening in India. People are left and right replacing the knee joint, which is not good. At the age where the patient has to have complete movement, they are restricted with 90 degrees of movement. So regeneration principle should not be forgotten, and high tibial osteotomy, I named this operation STO Revisited. Revisit this operation which is forgotten in India. High tibial osteotomy, excellent. Here I wanted to add, there is a ligament laxity and there is a shearing forces in the knee. We cannot only treat by bony correction. We have to don't forget about ligament laxity, and excellent surgery, Dr. Pele is advocated of shortening of the fibula, pulling the fibula down and shortening the length of the fibula will give a dynamic varus correction. See the result when patient is standing on the leg and take X-ray, and you will come to know whether varus is a dynamic or bony. Only correction of the bony varus is not going to solve. So tightening of the lateral collateral is also important to have a long lasting result. Second important point is external rotation of the tibia. By externally rotating the leg 10 degrees, you will improve biomechanics tremendously. If you have got a gait analysis, Anil Bhave from Dror Pele has presented his paper of STO which has failed. And he external gait analysis showed that external rotation improves the biomechanics tremendously. So rotation of the tibia 10 degrees with lateral collateral ligament tightening will give a very good result. Thank you.
Okay. So now supinion is the total knee. Okay, we'll show this case. Not no. STO. Okay. Now, what we have done, we have operated this case together. So we have done the below knee osteotomy here and the fibula osteotomy here in the same manner, and rotation we always do 10 degree. As soon as you cut the fibula, I tell you, the rotation corrects itself. And the illizarov frame had the 6 degree diameter of the threaded rod and hole is 8 mm. So it takes the rotation. We do 10 degree of the rotation.
Sir,
So,
should I interrupt for one?
yeah.
Just show the
इधर बोलो ना.
here. If you see, the biomechanical axis has got translation. There is a medialization of the tibia which should not happen. It should be a lateralization of the tibia and not medialization of the tibia. The osteotomy is gone with a spike on the medial side which cannot be lateralized. Very important that this spike will come in the way of lateralization and correction of the high tibial osteotomy. So your osteotomy should not happen like this, where there is a bony block for lateralization. That's why it is important to do Gigli's osteotomy. If you do Gigli's osteotomy, distract the osteotomy and then translate laterally, then the biomechanical axis will be straight. This is the translation of biomechanical axis which is coming on a medial compartment which is bad. We want medial compartment biomechanical axis should go on the lateral compartment, not on the medial compartment. If you see, you cannot correct biomechanical axis here because the spike will come on his way.
Anyhow.
Should I invite the comment
Okay.
of Professor Gubin?
Yeah. Please go. So after that. So what we have done, because it was so much severe deformity, so 20 degree was the valgus was achieved and 5 degree varus we have achieved. Now, this was the X-ray after 5 years. We have achieved 20 degree of the valgus. We have done more valgus, so that now you can see that here the degeneration of the medial cartilage. Cartilage on the medial side, there is a joint space which was not initial. In the both cases, they have done the very good the joint space. We have done this so much of valgus so that because the head tibia is collapsed, femur is also collapsed, so she have done the, and a very good joint space has been produced here. This is the follow-up after 5 years. And this is the follow-up after 10 years. So what we have done, same 20 degree of the valgus, which are initial, same degree of 5 degree of varus, they both are maintained. After this was a 65-year aged man. Now he is going to, after 10 years, he is 75. So you can see that still the angle is maintained there, same angle is maintained there. Now we have done the X-rays, the load bearing. So 20 degree of the valgus which was initially and 5 degree of the joint line is very well maintained. You can detect the joint line here. On the right side you can detect the joint line over here. And now it's after 12 years. Same 20 degree of the valgus and same 5 degree of the varus is still maintained. This person is using the bicycle, doing the exercises, lot of bicycle he is moving there. So after 12 years, this is the X-ray. Some osteophytes are there here, but still this joint is maintained. This joint is maintained. 20 degree valgus here, 5 degree varus here. Now we have taken the photograph of the stent space, same 20 degree, he was telling us the soft tissue, but till we are having the record of 15 to 20 years of our patients, we don't think there is any need of the, the photographs is there, he is having the 20 degree of valgus and 5 degree of varus. Now you can see the X-ray after 14 years. This is follow-up after 14 years. You can see the joint space here, and this is the follow-up of the 14. This X-ray has been taken 6 January 2012, and this is the photographs taken after the 6 January 2012, after 14 years. And this is the movie after 12 years. You can see that he is moving without any problem. He is moving, he is doing all his work there. Very good movements is there. Full range of movement is there. Now, he is using a cycle. This we have taken after 14 years. He came to us after 14 years. He are using a cycle and other things. So, what you think? What your comment?
All the time he is in cycle or this?
He comes to my hospital with the cycle.
What is the difference between right leg and left leg where
So
there is a
actually-
varus and valgus?
Oh, sir, when we have done that,
So
was a
clinically, what is the painful condition where it is in right side or left side?
So actually,
Or there is no pain on right side as well as on
he
left
is
side?
having no pain in any of the knee joint.
Sir, you have done an osteotomy in so many places in Tibula.
One place.
एक कुछ तो डिफरेंस होना चाहिए ना राइट में और लेफ्ट में क्लिनिकली क्या
On the middle level.
No, it's a middle level. Middle level. So,
It is a Uri-Sawa point.
yeah, it has.
Shift the mechanical axis according to what?
Visual point is a very severe deformity, sometimes difficult to control there. Yeah, we will take, okay. Now, actually what we have find out why we do the osteotomy below tibia, there is one of the cases who came to us with a fracture of the tibia in the various cases. So they got fracture here, so we thought it's better to do the osteotomy tibial tuberosity. There are many methods, alternative methods, a putty plate, I don't think it's a very good. Say another case, old lady, actually illizarov we are not using in the very old man, only in the villagers. So lady, we have developed another technique by Kosiko, he was dying for 40 years. What we do the Crohn's, which people are stud graft and 2 centimeter, 1.5 up to fibulactomy and the tomofix osteotomy. We will show you the result. This was a case who was having the 35 degree of the varus over here. What we have done about 10 centimeter below, we dissected the 1.5 to 2 centimeter the fibula. Because when we have removed the fibula, there is a flexion deformity of the knee. We took the tomofix plate and we take the Crohn's there, and the posterior portion of the fibula osteotomy side we have put that graft. Because we have studied and we have find out basically there is a flexion deformity. So when we put the graft of the fibula, second thing, when they walk, it can the spring effect there. They walk into the valgus thus there. So we remove this fibula, put the crown, and there's a Crohn's and there's a tomofix plate is there. And we have studied in the lateral view, there is no fibular defect is there. No flexion deformity is there. So you can see that case before surgery, and the whole thing is straight. She is walking. There is no deformity. We have a tube, the 70 degree of valgus. So it's a very good technique for the old people. So this is walking, beautifully corrected. Now what happens initially this is another case, we have put the Crohn's there. So the osteotomy was done there and this was a plate there. Now actually initially we used to take the iliac bone graft. And when we have done the studies there, we put the chrome. So what happens, because these old people has autograft, they are very weak. So this case, it has collapsed there. Initially you can see that we have achieved the 5 degree of the valgus by tomofix plate. But when she has started that, so because as the bones were osteoporous, there was recurrence of the valgus deformity. So we are not using iliac graft. Follow-up, regular follow-up at 2 weeks for suture removal, full-length radiographs. After fixator removal, 6 monthly follow-up for the loss of correction. Fixator is removed when there is a radiological evidence of union, when patient can walk pain-free. Frame should be removed in operation theatre. Partial weight being allowed with orthotic support. Advantage, adjustability, large bone-to-bone contact, stability. Disadvantage, technical defect, incompatibility with rotational correction. What are the complications? Pin site infection, loosening of the wires, breakage of the wires, knee stiffness, loss of correction, delayed union of osteotomy. Total number is 34. Anatomical angle correction is a 6 degree Gino valgus. Advantage, full tune adjustment, no casting, full weight 20, post-operatively, no bone graft, can incorporate correction of other angular deformities, neglect and discrepancies. Disadvantage, knowledge and experience needed, weekly follow-up, pin site infection is common. Controversies in STO. Osteotomy above or below tuberosity, fibula osteotomy or dissection of 2 cm fibula, fixation method external or internal. Conclusion, illizarov technique is a superior method to correct the deformity to a better anatomical options. Osteotomy is an effective, safe and cheap alternative treatment of osteoarthritis. Less chances of recurrence, patient is mobile. Now I want to tell you home message. When you correct the deformity, you should not go in the soft tissue pulling or other things. We are showing you the 15 years record of many patients. We cannot show you here all the patients. And I tell you, go to the home message, do this osteotomy. Above the 60 year, do the tomofix, chronome and fibulectomy. And below that, you can do the illizarov or whatever you want. And there is no need of any soft tissue. They all get failure in the long run. Thank you very much.
I think we have already discussed this in between, so there is no need of any question. Thank you very much, Dr. Agrawal.
I invite Professor Jhunjhunwala for his lecture on high tibial osteotomy, followed by his experiences with LRS. Dr. Jhunjhunwala.
लिखा था ना अभी किया ये वाला
Where is the program? Yes.
I take this opportunity to invite you all for 2014 Assami International in Goa, 18th September to 21st September. Don't forget to register early so that you will have less registration fee. 300 for foreigners, for Indians, 12,000 is a non-residential package, 12,000 rupees, which will include CME with Dr. Pale. Will start from 18th September morning, 9 to 1 p.m. CME, followed by 4 o'clock opening of the Assami International, and then 3 days full conference. Lunch, breakfast, dinner, everything included in the 12,000 rupees. So it's a very good package in a 5-star hotel, non-residential, 12,000 for Indians, and everybody should register for this conference. There will be feast of knowledge, and Professor Gubin has also said that he will bring a big team to Goa, and we have an interest.
Thank you very much. Nowadays, everybody wants to go for orthoplasty, but high tibial osteotomy is old is gold. Etiology of osteoarthritis is not clear. Incidence is about 40% of population affected over 40 years. Varus deformity, 90% of cases. Different theories for osteoarthritis. Predisposing factors as aging, inflammation, failure of cartilage remodeling, abnormal joint load, chytonic and catabolic enzyme secretions, and crystal deposition. You can see the difference between the normal and abnormal osteoarthritis. Why medial compartment arthritis occurs? Because the screw home moment of the medial condyle of the femur in terminal 20 degrees of extension may be the cause of initial medial compartment involvement. Pain is due to stretching of the nerve endings, microfractures in the subchondral bone, medullary hypertension, muscle spasm, capsular stretching, and synovitis. Grading of osteoarthritis is grade 1, 2, 3, 4. You can see different pictures where there is grade 4, there is a lateral displacement of the tibia. In OA, great disparity often exists between severity of the X-ray findings, severity of symptoms, and functional ability. This is very, very important seen in the clinically practice that the patient has severe pain, but X-ray shows very little change. Sometimes X-ray shows very severe changes of grade 4 osteoarthritis, but patient has no pain. So what is the rationale of HTO? Unloading of the medial compartment by correcting malalignment and redistribution of stresses on lateral compartment. So this is the way how the redistribution of the load from here to goes to the lateral compartment. Biological effects of the high tibial osteotomy is venous pressure is restored, increased intraosseous oxygen pressure, increased intraosseous blood supply, and pain conducting fibers are interrupted. What is the fate of articular cartilage? Magee said regeneration of the medial side of the cartilage occurs after high tibial osteotomy. Coventry said improvement in the articular cartilage occurs and further destruction is prevented. Ideal candidate for the high tibial osteotomy is active patient in his 50s or 60s, mild to moderate medial compartment changes, varus deformity less than 12 degrees, fixed flexion deformity less than 10 degrees, range of motion must be 90 degrees, minimal synovitis, no rest pain, no internal degeneration, and no ligament laxity. Contraindications are valgus deformity, varus deformity more than 20 degrees, bilateral or tricompartmental arthritis, fixed flexion deformity more than 10 degrees, range of motion less than 70 degrees, age above 60 degrees, large medial cyst formation on the medial X-ray, and marked ligamentous laxity. So you have to take a full weight-bearing X-ray of whole limb and draw the MAD, that is malalignment test. Non-weight-bearing X-ray has no meaning in high tibial osteotomy because you see here, you can see the nice, but same X-ray when the weight-bearing is taken, you see the medial compartment collapse. So weight-bearing X-ray is very important. So this is man with medial compartment arthritis, varus deformity of the left leg. You can see the X-rays, weight-bearing X-ray, and this is the preoperative X-ray. What is the planning? And this is the fixation doing after high tibial osteotomy above the tibial tubercle, fixation with the Coventry staple. So few operative slides. This is the transverse incision, exposure of the muscles, then oblique osteotomy of the fibular head, preserving attachment of the lateral ligament. You can see here the fibular head is cut obliquely so that articular cartilage is removed and some gap is created here so that when you do valgus, this gap fibula pushes up. Then the osteotomy of the tibia. A wedge is removed here, and as according to the pre-operative planning, the wedge is removed and the wedge is closed here. At this stage, one should check the alignment of the limb by cautery cord test. A point at the center of the head of the femur and center of the ankle, the cord should be slightly lateral to the center of the ankle. See, this is the cautery cord, ankle center, head of the fibula, and must fall little laterally to the patella. Then you have about 5 degrees valgus automatically. So staple fixation is done and skin closure, a plaster is given. Patient walks on this plaster after 3 days of the surgery. And after I remove the plaster, I give them this push knee splint so that they get better stability and they can walk better and less pain. You can fix up the different modalities of the fixation. You can fix up a blade plate, you can fix up a compression clamp, you can do with the illizarov fixator. Osteotomy distal to the tibial tubercle is slower and less predictable in uniting. Dome osteotomy are suggested by Professor Kashino of Japan, who has done the maximum high tibial osteotomies below tibial tubercle with valgus shift and fixed. This is valgus shift, always Kashino does, not the varus shift. And fixed with locking plate can be done to mobilize knee joint early. We have done 10 cases and we found fusion of osteotomy takes more than 12 to 14 weeks. HTO can be done by Lizaro's technique where there is a marked lateral ligament laxity causing marked varus knee. Here the varus knee is more than 20 degrees. You can still do a Lizaro technique without much degeneration of the medial compartment articular cartilage. By this technique, lateral ligament can be tightened by transporting the head of the fibula distally, and varus more than 12 degrees can be corrected by HTO with illizarov fixator. You can see here a lady of 40 years having marked medial compartment arthritis and marked lateral ligament laxity. You can see the lateral compartment is opened up so much. Even you do a normal high tibial osteotomy, in this case, this ligament will stretch more and patient will go back to the varus deformity. So what is recommended that a tibial osteotomy has been done, and you can see here this ring is empty ring except these two shank screws are fixed up over the fibula, and this ring is slowly distracted downwards. Thereby the head of the fibula comes down and stretches the lateral ligament. Thereby the lateral ligament gets tightened and you get some amount of correction. And once you do osteotomy, whatever 7 degrees wedge or 8 degrees wedge, you can correct that and fix up with the Illizaro rig. And you can see the result. This is the right leg where the operation has been done, and she needs another osteotomy on the left side, and she is waiting for that. You can see the leg is straight absolutely, and on the left side, what is the difference? About 20 degrees varus deformity on the left side. So with 25 degrees varus with marked lateral ligament laxity, corrected with closed wedge above tubercle osteotomy, with illizarov frame and head of the fibula pulled down to tighten lateral ligament of right knee. And you can see the difference between this and post-operative X-ray. And because it is above the tibial tubercle osteotomy, the healing is between 4 to 6 weeks. And patient is walking about on this illizarov frame. And lateral ligament gets very well tightened. Another case with varus deformity, again lateral ligament laxity. This is the weight bearing X-ray. And you have to do fibular osteotomy and put the illizarov ring, this is immediate post-op X-ray, and this is 6 weeks after X-ray. 6 weeks after this frame was removed, osteotomy is healed up very well. The fibular head has come down, the lateral ligament has been tightened.
Yes.
This is the 10 years post-operative result. Patient can squat very well after the osteotomy. This is 12 years follow-up with the medial compartment still opened up. And these are the moments of the high tibial osteotomy after fixation of the commentary staple. And the medial compartment still shows a good amount of joint space. And you can see other side where the osteo is not done, the joint space is reduced. So this is 13-year-old result with flexion, extension, and sometimes the age is no bar. This is a man with 73 years old, has early medial compartment arthritis, no lateral or patellofemoral arthritis. You can see in this X-ray, only medial compartment arthritis, lateral compartment is normal, and high tibial osteotomy has been done in this case. Osteo helped him last 1 year to walk about without pain. Complications: common peroneal nerve palsy, anterior tibial peroneal artery injury, overcorrection, undercorrection, too low osteotomy, osteotomy going into the knee joint, unstable fixation. Staple in the knee joints: when you put a staple, it can go in the knee joint, it can go in the osteotomy site, which will delay the healing. Compartment syndrome. To avoid this compartment syndrome, I always put a drain tube in the osteotomy area so that the whatever bleeding occurs can get sucked out and not go down in the leg to develop a compartment syndrome. Patellar tendon avulsion, infection, DVT, delayed union, and stiff knee. You can see the complications here. This is the unstable fixation because the staple has not gone properly. Another case showing the staple has gone in the knee joint. Third case showing the staple has gone in the osteotomy area. And this is a very severe valgus which has been done by high tibial osteotomy by somebody, and then patient developed pain. And you can see here, if you do more valgus, more than 10 degrees, they get pain and they require a total knee replacement. Non-union of high tibial osteotomy is also common, and you can see here the treatment is total knee replacement with a long shaft here. Infection, anybody can get. This is the comparative study. Roroback has shown that a 73% a good result in 5 years. In well-indicated cases, 95% in 5 years, 51% in 10 years, and in well-indicated cases, 80%. And at the age of, after the 15 years, the result goes down to 39% or 60%.